Actually, if you just Google monoclonal antibody, your general monoclonal antibody doesn't come up right now. It's your COVID monoclonal antibodies. We've been able to keep about 50% reduction in inpatient admissions and about 40% reduction in emergency department visits through instituting the monoclonal antibodies.
That's amazing. And probably the speed at which that had to be done.
It's really a great opportunity to kind of step out of our comfort zone and our box a little bit and play an integral role of the care of this pandemic and the care of patients during this pandemic as oncology nurses.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast.
I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Donna Bydlon, Network Director of Infusion Services at St. Luke's University Hospital and Health Network in Bethlehem, PA, and member of the Greater Lehigh Valley ONS chapter, to discuss monoclonal antibodies to treat cancer and COVID-19 and considerations for nurses. Thanks for joining me today, Donna.
Thank you for having me.
So to start us off, what are monoclonal antibodies and how are they used in cancer care?
Well, monoclonal antibodies are basically a part of our immune system. And what they are, they're basically system proteins that are generated in a lab versus our body producing our own autoimmune responses to things. So we all have antibodies in our body that are produced and that will fight off diseases and infections and help our immune system to fight off those disease and germs that we come in contact with. Similar to how our own bodies and our own antibodies work in our body, monoclonal antibodies recognize specific targets on cells and begin to stop and work against the disease. So in the case of cancer, what happens is that these monoclonal antibodies are developed to control how cancer might grow, whether how the cells divide, how they spread, blood supply, and they help some of them help the immune system to destroy the cells, to destroy the blood supply to the cells, to stop signals from the cell growth from duplicating. They can work in various ways. They help to deliver cell-killing substances to the cancer cells that can help cause cancer death and kind of target that cell and kind of almost like an alert response to the body when it notifies and sees that cell in its system. So that's how most monoclonal antibodies work.
Okay, so since they work maybe a little bit different than the traditional chemotherapy worked, what are the nursing considerations when administering these types of medications?
So normally in our infusion centers, all of our nurses take the ONS chemotherapy biotherapy course, and we're all trained and instructed on how to handle chemotherapy. And we handle our biotherapy and our monoclonal therapy agents similarly. So really what we need to have the nurses to be educated on the proper handling and administration of the drug, and also be able to be knowledgeable of the potential side effects of the medications and the management of those reactions if they should occur. So if the patient should have an anaphylactic reaction, and so you have your emergency hypersensitivity kit available that you can administer to the patient right away. Those are the two really key important things. And then, of course, wearing proper PPE in the administration of the medications.
Okay. You did mention PPE. What are some of the safety concerns and how can nurses navigate that?
In your plain infusion center, your everyday operating infusion center, we are wearing gowns and we are wearing our double gloves. And according to our ONS guidelines, when handling monoclonal antibodies, just like we do our chemotherapy. So that's what you should be wearing in your everyday handling of monoclonal antibodies in your general infusion type setting or on the floor on the inpatient side. In a COVID type situation, of course, you're wearing the same PPE, but also you're throwing on to your N95 or your PAPR and your goggles and your face shields and things like that.
Okay. You mentioned COVID. So we're going to start talking about that a little bit.
Mm-hmm.
With the pandemic and looking at options and how we're treating this, what and how are oncology nurses instrumental in implementing this infusion?
So it's funny that you asked that question. So way back in October, if you would have said to me, infusion nurses are going to be involved with treating COVID positive patients, I would have sort of chuckled and laughed and thought, well, maybe in the realm of giving a COVID positive patient a blood transfusion after hours or some sort of supportive therapy, but not in the situation that I had no idea was coming. So about a week before we opened our clinic, we got word that these monoclonal antibodies were coming out and we're going to get emergency use authorization. And that was the first that myself and my team learned about these. So we kind of came out of the gates running, and the leadership looked to the infusion center staff because we're so used to giving monoclonal antibody infusions every day. Taking care of these patients and handling any type of reactions is second nature to us. So we don't hesitate at all with the safe handling and administration. So they really led to infusion and looked to our team to kind of say, can you help us with this? Can you help us get this up and running? What does this look like? What do we need to do? And how can we roll it out? And that's where oncology nurses came a big part of that. Since we know we're responsible for the instrumental implementation of protocols for the use of different monoclonals in the units with our educators, that this was like second nature for us. So we were very helpful in the implementation of protocols due to our extensive experience and knowledge base with handling other monoclonals and chemotherapy agents, whether it be for a cancer or non-cancer diagnosis. And then also, again, reinforcing the fact that we understand how to monitor these patients, what's involved in handling the medication, what side effects you need to look for, and then also how quickly you need to react to these patients if they should have a reaction during the infusion. And then it all took off from there.
You know, that really is interesting. Kind of like you said, you never thought that oncology nurses were really going to be involved at that level with the COVID population. And I'm sure that really did take a drastic turn for many, many institutions, because that's not who had been involved in the care of that group of patients throughout all of this. And now all of a sudden, here's a therapy that is not something common or that these other patient areas are familiar with administering.
Correct.
Are there any additional considerations or adverse events, safety concerns, anything like that with combination therapy that, whether it's our oncology nurses or other practitioners that are administering this, they should know?
I'll be honest, we have not seen one infusion reaction in any of our patients while in the infusion room, of the COVID infusion room, during any of our treatments. And we've given close to, by the end of this weekend, we should have our 1,000th patient that we have treated. So we haven't seen any infusion reactions at all from any of these monoclonal infusions.
Wow, that's great, because we all know that is definitely one of the things that we look for whenever we're giving those types of therapies with patients. So that's amazing.
Right. And we do, the infusion runs, and then we monitor the patients for an hour afterwards. And we haven't seen anything. We, of course, we've had a couple patients that maybe have come in for their appointment and maybe their stats were too low and they never even got infused. We sent them off as a medical emergency to the emergency department. And we did have one gentleman that had a reaction, but it was not related after in the observation room. It was not related to the infusion at all. It was related more to his disease state with COVID than anything. So yeah, it's been quite successful with doing this in our network.
Great. So what do your ED nurses need to consider when administering monoclonal antibodies? Is that where, I guess I'm asking that, but you also just said that you guys are seeing the patient. So maybe talk about what they might need to know for this.
Sure. So I can tell you a little bit how we set up our scenario in St. Luke's University Hospital and Health Network here in Bethlehem. We were fortunate enough to have two sites at two of our hospitals, our Easton campus and our Warren, New Jersey campus, that we had room available to actually turn these units into a a COVID infusion center, negative airflow and everything, so that staff could be in those rooms in full PPE, PAPRs, N95s, face shields, full protection, caring for these patients from the time they came in to the time they were done with their observation. At one point, we had so many patients that we had to create an observation room down the hall so we could get in about 21 patients a day, kind of during that peak surge that we had. So really what we were doing is when we created this and we had to do this quickly, we were staffing with a lot of the infusion center staff, taking staff out of some of our infusion centers that volunteered and then backfilling those holes. And then we quickly posted positions in our network for reserve nurses to pick up time and work extra in these units. A lot of our nurses that picked up time were our AD nurses, some were critical care, some maybe came from a PACU type of background. So it was really nice because the emergency room nurses are very quick to pick up the fast pace of an infusion center and the critical thinking that needs to go behind in case that patient does have a reaction and what's all involved. So really what we did was we came up with tip sheets for all of our nurses that were stepping into the room on the drug and the side effects, educated them on our EMR. We're all on Beacon and Epic here in the network, and the infusion centers are on Beacon. So the plan for the therapy for the monoclonal antibody was created in a therapy plan. We then had to educate those nurses how to access our plan. They got IT access and how to follow the flow and the charting and the documentation, and then also spent time with them. We'd have them come and orient and spend a shadow day or 4 hours, however long they could, to kind of see the workflow and get a feel for the unit and kind of work side by side with an infusion nurse. And then we gradually got everybody up to speed, educated them on everything and all our processes and how to handle, dispose. They understood already the general PPE requirements for COVID patients and the donning and the doffing that were involved. So that was actually new to more of the infusion nurses than to the staff that came to help with us. So we had to learn all that stuff and really refresh our old nursing pieces of stuff because we don't usually don and doff in our units at all. So it was really a great experience for everybody involved. So really the nurses all fell in really well. They all quickly jumped on board and quickly became experts in a field that they probably never thought that they would be doing either.
That's amazing. And probably the speed at which that had to be done.
It was like 72 hours, days that it happened. It was like within a week we were like up and running, and it was pretty fast.
You talk so much about, the training that you guys did for the non-oncology nurses and just kind of how you got them up to speed. And so much over this past year has just been so much learning. I mean, in oncology, we're kind of used to the treatments changing and new drugs and everything happening so quickly. But for everyone to have to kind of move on that fast moving train and get up to speed and do all of that, it has just been amazing. So how has your institute adjusted to administration process as the pandemic persists?
So right now we continue to have our little satellite units. We actually opened up a third one up in one of our campuses further north to be able to have closer access for those patients to their homes. As of right now, we're starting to see it slow down a little bit. Although, COVID obviously is still very much out there, we're definitely starting to see the volumes come down in the number of infusions that we're doing a day. Our plan right now is to continue to keep these COVID infusion centers open. But what we'd like to do is eventually get this to run through the emergency departments and kind of get some training there now that the surge is coming down. They're not holding in the EDs. Patients that maybe are coming to the EDs can get a rapid test done. And if they meet the criteria for the EUA, they can get their treatment in the emergency department and not have to make another trip out. Our current process has really worked really well. It was kind of kicked off with one of our PCPs, primary care physicians, and one of our infectious disease doctors, and that's how the process got started. Patients work with their PCP, they get a positive COVID test, then the physician, the PCP, reaches out to the infusion centers to schedule the patient. They put the plan into Beacon, and they have a smart set built with their documentation that kind of drops in right away, the onset of symptoms, all the EUA criteria and consent, everything met. and off day, then they come over to us. And then there's a requirement of a 24-hour virtual visit done with the PCP after to follow how these patients are doing. So we have a lot of metrics in place to be able to pull out that information, that data, and see how these patients are doing. And to date, last week, our infectious disease doctor mentioned that we've been able to keep about 50% reduction in inpatient admissions and about 40% reduction in emergency department visits through instituting the monoclonal antibodies. So they feel that's very successful, and they're still collecting data as we move forward.
That's really amazing. And, just as you're talking through this and talking about all of the charting and the electronic medical records pieces that were part of that, and then all of the different multidisciplinary team members that are part of this, what a huge, huge task to get that turned around. Like you said, whether that was in that 72 hours and, making sure that everything was taken care of and all those pieces were in place, but the communication and collaboration during all of this. Can you talk about that a little bit? And, just because that's huge.
Yeah, absolutely. It's been phenomenal. I have to say, when you work in oncology in an outpatient setting, you kind of are in your own little world, right? You kind of deal with your people in your oncology service line. Occasionally you're reaching out to your non-chemotherapy providers, for those needs and stuff. But in this type of setting, like we really at each facility got to work with the different leadership teams at these facilities and work with our PCPs, from the heads of environmental services to engineering and facilities, helping us get these units up and converted to negative airflow, get all of our supplies and dietary needs, the emergency departments on site and the heads of the emergency departments, the physicians that were a great resource for us and would come up and check in on us and see how we were doing, and the staff, and working out the process that, okay, if patients have an emergency reaction, this is what we're going to do. And the responses to those, we needed to call a medical emergency, not due to reaction. More of ours were related to patients coming in so ill that they couldn't even receive the drug when they got there in the beginning. So it's just been phenomenal. And we actually have a daily call every day still at 4:00 where we kind of go over how the day went, any problems, any issues, what could we have done better. Pharmacy, of course, has been a key player in this as well with us. We always work closely with our pharmacies all the time, regardless. But, they're dealing with the monoclonals, and now they're dealing with the vaccine rollout. So they're pushed in a couple of different directions, along with everybody is stretched so thin. So it's just been absolutely amazing. And I know from my team of infusion and oncology nurses, they really feel thankful to be able to have this opportunity to kind of play their part and their role in caring for our COVID patients. Because during the first surge, we were on the outside watching and feeling bad and hearing how horrible things were on the inpatient side. Our friends and our coworkers maybe that we know that work in the units and in med surge, what they were going through every day. And when you actually see how sick these patients are when they come in, it's a totally different appreciation of what actually has been happening. So we are very grateful. It's been a really wonderful experience to be a part of being able to give back and contribute our skills to helping take care of our COVID patients.
What a great way to say that, because I think that we definitely have seen over the past year just so many different aspects of this. And from like what you're saying, the early points where, maybe there weren't oncology units or inpatient or outpatient that weren't as busy as definitely everyone else was because of that surge and where the COVID patients were going and the enormity of everything. And then to get to this point where you really do, you feel like now we're able to jump in the game and, we're kind of in there to help almost in a relief kind of situation where now, unfortunately, it's not complete relief, but now there's some extra hands that can be put in and help out in different ways and help the process and that communication and just treatment options and things like that.
I agree. And I'm so proud of my nurses. I mean, they Some of them did not even hesitate to throw on that full PPE and be in a room for 8 hours, except to, go for a break, have lunch, and come right back in. That's a lot, and it's a lot to be in that full PPE for 8 hours, but they have been doing it, and they're just phenomenal. And, every nurse out there and every essential worker in healthcare that's been doing this for this past year, it's just amazing. This has been a lot and quite a journey. So the fact that we can help keep patients out of the hospital and help make them feel better. I mean, a lot of our patients have said almost like either that night and the next day they felt so much better. Their symptoms didn't get any worse. It's just amazing with these medications.
It really, really is. And I mean, how grateful I'm sure that everyone is that there was something that was identified so quickly. I mean, people might not think it was quickly, but in, the grand scheme of things, and having how many new medications approved so quickly for this is really just amazing.
Agree.
I have a few questions to finish us out. First of all, what are some common misconceptions about monoclonal antibodies, just kind of in general?
One of the biggest misconceptions is that people think they're only used to treat a cancer diagnosis. There are so many monoclonal antibodies out there that are used to treat a lot of autoimmune disorders, rheumatoid arthritis, Crohn's disease. We have some that are definitely used for your non-cancer diagnosis, but there's just so many out there. Every commercial on TV almost has another monoclonal antibody targeted therapy out there, from psoriasis. It's just amazing. And I think that's a misconception, and that they're scary and it's a type of chemotherapy, and it's really not. And I think having outside staff being able to see this has been a great thing for to spread the word on the education, and that they're very safe, and that using them and treating them, and as long as you're handling everything properly, it's very safe method of taking care of patients in all types of diseases.
Very, very true. And you're right. We do see monoclonals on our commercials. And so they are probably more common than people realize. And so it is good to have them understand that they can be given, and they are given safely and things like that. Good point. Next question. What's something about monoclonal antibodies that's not often discussed, but you wish people knew more about?
I think probably would be the similar part, that they are very safe, that they're not labeled as being a detriment or, the possible long-term side effects of anything really, and that it's just not labeled as a cancer medication. I think that's probably the key thing, that I think really the benefits outweigh any risk with these drugs. I mean, even for something as simple as osteoporosis, where you have, your Prolia out there, it's just education of the public and understanding. I know some of our patients were afraid and nervous to get the medications, and what is this really going to do to me? What's the long-term effects? And even when I talked to some friends, they were unsure. Family, what are you giving? Why? I don't know if I'd want that. I think it's just really just education that is really, really important. And I wish that was really pushed out there. I know as our network, we've really pushed it out a lot of education in the community, kind of blasts and stuff like that constantly to our community on what this medication is, and to our providers to educate them so that when they see a patient, that, hey, this is an option for them.
Other really great points. And you just kind of hit on my last question when you were talking about getting the education out to the community. I wanted to ask you, what are some additional resources, both for patients and providers who want to learn more about these treatments?
I would say, definitely referring back to the pharmaceutical companies that are making these products. There's a lot of information out there now. Actually, if you just Google monoclonal antibody, your general monoclonal antibody doesn't come up right now. It's your COVID antibodies, monoclonal antibodies, that are first to come up on a Google search. So any type of online resources, of course, a very respected and valued resource. You're not going to go to Wikipedia or anything like that for any of your information. And then, of course, your physician leads in your institutions, your infectious control doctors, they're very extremely educated on a lot of these things. I myself have learned so much from our experts over the past several months that I never thought I would possibly know. There's really, and your nurses, your infusion nurses, your oncology nurses really can be a great champion for educating a lot of people on the use of these medications.
Excellent. Well, Donna, I want to thank you for being with us today. You can hear the excitement in your voice about the work that you guys have done and your staff, and just how you have been able to participate and help out those other healthcare workers that have been in the throes of everything with COVID in such a different way, and what you guys were able to do. So do you have any final comments for us today?
I would say to any oncology nurses out there, or any institutions that are being maybe questioned or asked to do this, I would not hesitate. I would not be afraid. Definitely, work with your leadership team, reach out to your resources. It's really a great opportunity to kind of step out of our comfort zone and our box a little bit and play an integral role of the care of this pandemic and the care of patients during this pandemic as oncology nurses.
Well, thank you again, Donna. I really appreciate you being with me today, and congratulations on a great job with what you and your staff have done.
Thank you so much. And again, I appreciate you having me on.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.